Good morning. We're going to go ahead and get started. I have the privilege of introducing Dr. Denson. My name is Beverly Hutcherson. I am a diversity manager with the Office of Diversity, Equity, and Inclusion, and I work very closely with the team within the Department of OBGYN. I'm also a graduate student in the Endocrinology Reproductive Physiology training program. So I'm really excited for you all to hear what Dr. Denson has to offer us this morning. Dr. Jill Denson is a research assistant professor at the University of Madison School of Medicine and Public Health. She serves as the director of the UW Prevention Research Center, engaging researchers, community members, and translational partners in the expanding community-based prevention research, as well as health promotion to improve the health of women, infants, and families. Dr. Denson is passionate about maternal and child health, sexual and reproductive health, and health equity, with a focus on examining how social and structural drivers affect health outcomes. Dr. Denson's research interests are rooted in collaborating with community partners to address health disparities through community engaged research. She is particularly interested in building robust community partnerships and centering voices of those who are marginalized through capacity building and innovative research strategies. With that, we will hear from Dr. Denson herself.
Thank you, Beverly. It's really weird. I can't see you guys at all, but I'm told that you can see and hear me. It seems like a lively crowd there. I'm not lively at 7:24 in the morning. So hopefully I'll perk myself up and we can have some interaction and dialogue after my presentation. I'm honored to be here and to talk to you all today. I was asked to come and really talk about the UWPRC, a little of my own research, and then the research agenda of the PRC and how we can collaborate. I am, as Beverly mentioned, I am housed in SMPH in the pediatric department. And how I got in pediatrics and how UW PRC got in pediatrics, we'll talk about on the next slide. I think it's always important to ground. My work is really heavily into intersectionality. So I like to ground positionality and identity in all my talks. So surprise, I'm an African-American woman. But I am also a person who I was born and raised in Milwaukee, have strong ties in Milwaukee and in Wisconsin. A lot of my passion comes from outcomes, particularly that happens here in Wisconsin, which is many times very negative for African American and indigenous communities. And so that is a lot of what my past work has been about, what my research is about. I think it's also important that I name how I go about my work. I don't know why I'm always thrown off by the term DEI. I'm not opposed to it at all. But I think it can be used to as a checkbox, checking that off. It could be functionary. It could be very passive. And in my work, I try to be the opposite of all of that. So I also name directly racism, sexism, classism, and how those isms really impact social and health outcomes. And we won't get into it today, but I want to remind you, and I'm probably going to go back to it. I never talk about 2024 or think about 2024 and health outcomes and what's going on in the state of the world without thinking of historical trauma, thinking of how we got here. So I'll probably intersperse that as I go. All right, so the history of the UWPRC, it was we receive CDC funding. There are currently 26 CDC funded PRCs across the nation. In September, that will change. There's less funding, so it is now 20 centers across the country, so a lot more competitive in this next when we competed for the new round of funding. So the current funding will end in September 2029. And so I'll get into that after this, but this funding was from 2019 to 2024. I'm not sure even how we became a center, how who thought about that, why the university wanted to pursue this road, because in order to become a center, you either have to have a preventive medicine residency program, which we did not have prior. We had to implement that in order to even apply for funding, or you had to be a school of public health, independent school of public health, which we are not. So the powers that be decided to start and implement a preventive medicine residency program, then apply for funding, which we did, and we received. So the folks that wrote the proposal, probably back in 2018, decided to focus on maternal and child health. So for all the CDCs, there is a focus on health equity, applied public health research, and a heavy emphasis on community engaged research. So those are things that all the centers have in common. Again, we focused on maternal and child health. We could have focused on, just Milwaukee or just Southeastern Wisconsin, or, just one health department, as evidence in other centers across the nation. But we decided we would focus on all of Wisconsin. We'd focus on maternal child health. And it was very explicit throughout the proposal that we were going to focus, we as in Wisconsin and the PRC, we're going to focus on low-income women, infants, and children. And that always bugged me. I became involved in the PRC in 2022. So this is, well up and running. It always bugged me that low income, because I felt like that low income was a proxy, probably for race. And it just bugged me that, that we didn't call a thing, which I think is really important, especially when you're doing prevention research, you're talking about equity. So when I had the opportunity to compete again, did somebody ask a question? Okay. When I had the opportunity to write again to compete for this new iteration of the grant, I was very intentional in changing that. We still stayed in Wisconsin for various reasons. I thought that was important, although much of our health disparities are based in race. And with the African American community being the #1 for poor outcomes, which is not a badge of honor for us, by the way. But most of African Americans in Wisconsin really live in 5 counties that are in the South and Southeastern Wisconsin. But I did feel like it was important to address disparities and MCH related issues throughout Wisconsin without taking that emphasis off racial health disparities, which I think is very important. Prevention, we are really in the CDC, we are under like the chronic disease prevention category. And we are the only we are the only PRC that focused on maternal child health. As you know, there are a lot of drivers that really start in that, pregnancy, infant stage that later develops into chronic diseases. We don't know as of today, we don't know who the other 19 centers are and what their focus is on. So we may remain the only one that is really dedicated to maternal child health, or we may be one of a few. Um, so I want to talk about leadership changes in the PRC. So the PRC, is funded for every 5 years. And I am the third, in the 5 year period, I am the third director for the PRC. So there's been different leadership changes. The two directors prior to me were um, academic physicians, one a pediatrician, one I believe internal medicine. And so, their journey to this position is a lot different than my journey. Again, we're talking about identity and positionality. So I bring myself as someone who has been a master level social worker, mainly in Milwaukee County for the last couple of decades. I have my PhD in public health. So, my positionality and my interest are a little different than the other two leaders. Not saying that one is better or worse, but how I show up and how I show up in this position is obviously going to be different. Community engaged research is really a passion. Like when I was, it's odd, but when I was in working on my PhD, I never saw myself as a traditional researcher. I didn't, and I remember that many of my professors would say, well, can you really talk about public health theoretical frameworks? What is all of this like Sojourner syndrome, strong Black women trope, intersectionality, critical race theory, historical trauma? What does that have to do with the price of beans, and why are you talking about that in your papers, in your research? I got a lot of pushback when I was in my prelim status, but if I was going to invest time, energy, and a lot of money into getting my PhD, I wanted to do it to really, as much as I could, to activate and work alongside community, particularly communities who have been marginalized in our society. So community engaged research to me, I mean, some people will send out a survey. Like I just got a survey from Target, and then that is community. You've engaged the community. And I'll talk about that later about continuum of community engaged research, but being very, very intentional in our new proposal on talking about what community engagement would look like. I wanted it to be alive and breathing and in partnership with the community, and not just a checkbox. So because I am, the third leader, and we've been given the green light that we will have a center for another 5 years. And it's like the most unkept secret in the world. We haven't had kickoff emails and kickoff events because I didn't realize this until COVID happened, that the CDC is really controlled by Congress. I had no idea about that, including funding. And if you have paid attention to the news at all, Congress has been delayed on a lot of decisions. So we have been officially approved for funding. We are just waiting, along with a lot of other funding decisions, for it to be like official. And then you'll probably get tired of hearing us, and we'll be doing a lot of kickoff campaigns. But we have been approved for funding, just waiting for like the final approval from Congress. So because I'm the third leader, and because we're moving We're keeping a lot of the same, mission and vision, but we have changed that, right? So when I'm talking, I'll be talking about what happened, how we started, what we're doing now, and what we are planning to do in the future. So I'll be going between those. So each PRC is required to have a community advisory board, which I'll be referring to as a CAB. And it's really up to us how we utilize our CAB. The great Sherry Johnson, who is the leader of the PHF Public Health Institute, she was really instrumental in writing all the community sections in the first proposal and really helping me think through her vision that wasn't realized in the first proposal and how to also think of things going forward. So Dr. Johnson's vision and what we kept is really equal representation from organizational partners. So people who work in social service organizations, public health organizations that are specific to maternal and child health throughout Wisconsin are the organizational partners. And then family circle members are your everyday citizen who have some direct experience. Some people may have previously had a poor birth outcome. They may be very, a grassroots person in their community. They may be, a doula. They're just more personally impacted. This is a part of their identity without being, paid for it. We have co-chairs. Our co-chairs, one represents the organizational partners and one represents the family circle members. We are now have them as a part of our steering committee, which was traditionally made up of tenure track, associate level and above academic professors. I'll talk about that a little later. I've done a lot to make that a lot more diverse and inclusive of academic staff and community staff. And so originally, I think that our CAB was really utilized in a very passive way. I did mention each center has a core research project, which I'll talk about in another slide. But I think that our CAB was maybe the core research project engaged them once a year and said, hey, these are the things we want you to look at. Tell us about it. We'll see you again in a year. We have a small grants program. And there's an academic review, and then narrow down that, and then it goes to the CAB, and then the CAB reviews, and the CAB helps decide who's going to get funded. So not quite passive, but not totally engaged in that project. So we want to give a CAB a lot more autonomy and decision making. We knew that it was important, and we talked to them about it is important to go through that academic review because we want this to be seed money for researchers to go on and do more research, and so they need to be able to have a competitive process and have the best project that they can, and the CAB was really okay with that. But we changed it to really they will have the review. They would be able to ask small grant recipients, not recipients, but people who were applying for small grants or competing for them. They would be able to ask them questions and then be able to make the decision on who would get the small grants. We've changed it to having so that is still existing, but we've also added project subcommunities. We've done a lot of work since I came on board in people who are just not really engaged in the CAB, helping them be okay with saying goodbye. And then really trying to add people who are really active, engaged, and really passionate about maternal and child health, and usually specifically in their little region or area of Wisconsin. And so we knew that everybody can't do everything because CAB members are just like us, extremely busy. So we, fund them, give them a space, autonomy and decision making to be on various projects. And so that has just begun. So far, we have two project subcommittees, and that will be growing. In events, CAB members are involved in helping us plan our annual meeting. Not as much as they will be, but they have started that. But we really have started them being co-presenters. If you were able to attend our last annual meeting in October, our co-chairs are the ones who emceed the event. And we had, many members of our CAB who were presenters. We went to APHA in Atlanta last fall, and we were able to have 3 of our CAB members attend, 2 from Family Circle, 1 from the organizational partners. And they were able to, make a lot of connections on their own, independent of us. Also new in this iteration of our funding in our 2024 through 2029 funding, we have an associate director of community engagement, and she is actually a CAB member, Family Circle CAB member, and she's not a checkbox. She's well known in Dane County. She's a trained doula. She has a degree in child development. She is somebody who is, very bright and intelligent, will often push back. It brings a lot of constructive criticism, a lot of fresh ideas. So this is not somebody who is a checkbox at all. So we're really excited to have her on board and make sure that we are really activating community voice and community engagement. We're expanding our membership. So this is a map of Wisconsin. I like the Wisconsin Public Health regions, a regional approach. So I really want to make sure that we have at least one family circle or organizational partner in the 5 regions. And we also know that, it's very hard to be like, I'm the only one representing, the Northwest. So we want to make sure that we have that representation, but we also want that CAB member to help us build other relationships in all of the counties, because again, CAB members are very, very busy. It's not their responsibility for us to make sure that we are engaging with community residents and community organizations and public health departments throughout Wisconsin, but it'll definitely help. We want to be very inclusive. We know that rural areas, they have, a big thing that is affecting rural communities is OB deserts. We don't know at this moment, it doesn't seem like it has been impacting their outcomes, but we know that it probably will, right? That's a big issue. Transportation, access to care is very different when it's not in your county and it's maybe 2 or 3 counties from you, and you don't have reliable transportation or any transportation. So we do have some partners who always raise issues with us about what is going on in rural communities. And rural communities are also going to have migrant workers. They're going to have, immigrants that are new to us, in, Somalia, possibly Ethiopia, Ukraine, that are going to have issues, potentially have issues that are different than ours. So we do know that those groups that I just mentioned often will have, will come from a war-torn country, come here to the US and have like just beautiful birth outcomes, which you wouldn't expect. And then, here is a Black woman whose ancestors have been here for centuries and have these like deplorable, birth outcomes. So very cognizant of that. So when I talk about engaging community, again, it can be anywhere from, you know, throwing out a survey on, online, all the way to the gold star, which is CBPR, community-based participatory research, which, is growing in popularity, but it's very difficult to do in an academic setting, especially if you're somebody who is on a tenure track. You're probably not going to do CBPR early in your career. Like it's just not going to happen. It takes a lot of time to build trusting community relationships that are bi-directional, that the community has either brought the research question to you or helped you develop the research question, helps you, think about funding sources, has equal ownership, who, from the research question all the way through conducting the research, writing the manuscript or having input on the manuscript, doing presentation, co-owning the data, is very different than throwing out a survey online. So I would say we started at outreach, and I want to say we probably are dabbling between involve and collaborate. Like we're probably going back and forth, back and forth. Again, this is not an easy process, especially to do it in an academic environment. The CDC actually, they really prioritize proposals that were CBPR. Although everything that they asked for in the proposal was almost in directly, against CBPR methods. So again, it was sort of like a checkbox. That would be great if you could do CBPR, but we're going to put in this proposal that you must answer things that really don't align with CBPR. So we did our best, and we're all, we throw this up a lot because it just reminds us where we came from, and we don't want to ever just be at that first outreach. But that is a continuum, and that it is really, really hard work to build trusting bi-directional relationships with communities, especially communities who have been harmed for generations. And there's some people that I say, hi, I'm from UW-Madison, and they're like, oh, great. And that gets me to the door. And then there are other folks who are like, I am so tired of these people. They come here, they ask me a lot of questions. They, they dredge up really personal, painful things. And then they're like, bye, and I don't hear anything else. And that's, of course, that's not just UW-Madison. That's all, that's a criticism, a rightful criticism of academia. So we're moving forward, and our gold star is CBPR. So we also, from the first iteration of our work, we had a translational partners panel, which were organizational partners that worked in, public health, in social service organizations, all kind of organizations, again, that were directly or adjacent to maternal child health, that were positioned to take research into practice. So that is another big thing of the PRC and the PRC models, is to really data into action, make research alive and well. So when I'm thinking of research projects, or what we're doing now, what we're doing in the future, and collaboration, I'm always thinking of how can we make this live and breathable for communities? How is it going to impact those communities? And then also, if I'm working with I just want to give you a quick example. We're having a CAB meeting, and one of our partners works in the health department in Barron County, which is in the northwest of Wisconsin, and she was talking about the Somali refugees. And then we have a CAB person in Milwaukee. He doesn't work directly with Somali refugees, but they're a large population in Milwaukee too. And he was like, oh, I'll tell you some of the work that we're doing in Milwaukee. And so that is really another goal, is um, to respect people. They're prioritizing what's happening in their own communities, but to also understand what is happening in your community could be happening in another region or another area of Wisconsin, could be happening at this moment, or could be happening in another 5 years. We can prevent that or minimize that if we work together and we're not siloed. And that's another thing we try to do in our translational partners panel, TPP, is take people who have various backgrounds and various specialties, and help us really take the research, make it live, make it mean something. What we're doing new is, and they've actually asked us. I was really surprised. The CAB meets very regularly. The TPP, not really. They meet once, maybe at the most twice a year. And busy professionals, getting them that you're only meeting with them once or twice a year. You would expect, like, a lot of people not to show up, or like to be quiet, have blank stares. And they are like so motivated. They always bring a lot to the table. And they've actually asked us, like, hey, we want to be more involved in this, which rarely happens with a group of busy professionals. So we're going to take them up on that and provide greater involvement for them. New this in 2024 through 2029 is we're going to elect co-chairs, and they will also be in our steering committee. And the hope is that there will be more CAB and TPP connection, that they'll be working offline together. And also new is faculty advisors for translation, dissemination, and implementation. So I also wanted to have sort of the theme of what we do for TPP, but really think about it more day in, day out with people who do research. And so we have a pretty diverse group. I try to make sure we have people in peds, OB, family practice, social work, and so forth. Also, we've given 0% faculty appointment for our partners in DHS, Department of Health and Human Services, specifically in their Department of Public Health. So we have a person from the chronic disease unit, and also a person from the maternal mortality unit, who will be working with this group. And I forgot to mention, or I didn't mention, that in our steering committee, we also have a person who is Dr. Jasmine Zapata, who is a pediatrician at UW, and she's also the leader, along with Dr. Jackie Adams, in maternal mortality review, and she's the public health doc at GHS. She will be in our steering committee as well. And speaking of Dr. Jackie Adams and Dr. Tiffany Green are, both in this group of faculty advisors. I'm sure you guys know them well. So I chose very, very carefully. I chose people that I knew who weren't going to be yes people. They were going to bring fresh ideas. They were going to be asking the tough questions to really make sure that we were engaging communities and bringing research and disseminating research back to communities in various ways as quickly as possible. So I just want to talk just a little bit about, so I'm a newbie. I just earned my PhD in 2021. So, I'm a normal researcher, so I want to talk about my own research. So my research was titled The Impact of Structural Determinants on Pregnancy Intention and Reproductive Decision Making Among African American Women. Now there's a lot in the literature that talks about, why don't Black women take birth control? Why do they have unplanned pregnancies? Why don't they want to, come see us? It's tons of literature like that. And I didn't feel like it was necessary, neither did I want to produce anything like that. So and I work, a lot of my specialty is working with pregnant women through the postpartum period, through the early postpartum period. And my interests was doing these assessments where a lot of women said, I really didn't plan this pregnancy. I'm fine with it, but I didn't really plan it. And I'm such like a planner. And I know life happens, but I have to like certain things I just have to have planned out. Otherwise, it makes me feel like a loss of control. And so I was really, really interested about, and I love birth control. I think birth control, the ability to vote and go to school have been game changers for women. So those are like my three things that I love and am passionate about. But it was very interesting to me, but I really want to talk about structural determinants. So I really want to ground this in historical trauma, intersectionality, critical race theory, really to try to dive into what went into women's decision making. I wanted it to be participatory. I used group concept mapping, which could be done online, but I, felt it was necessary to do it in person. When you get a group of women, and Black women are no different, and you have a group and you make it a very comfortable situation. You're sitting around, food. You can have a sense of community and talk about things in a trusting environment. I didn't want to do the traditional compare Black women and white women, because it seems like white women are like, the gold star. That's what we're trying to get to. We're trying to get to the behavior of white women, which for me is not true. I wanted to compare Black women in terms of income, because we know the literature shows us that, unfortunately, like other groups, education and income are not always protective factors for Black women. So shout out to Jenny Higgins. She texted me yesterday that she's not here today, but she was on my dissertation committee. She was very supportive, remains supportive to this day, but she was that person who, always asked the tough questions, made me think of things differently. So shout out to her. So I have realized you're like, I have no idea what this means. And this is not a presentation on my dissertation work. I've already done that, I think in 2021 for a core presentation. But I just want to give you a graphic so you get sorted, because a lot of people don't know what group concept mapping is. So I just want to give you a graphic. And these are the themes that came up. I didn't name these themes. It ended up that the participants named the themes, came up with the theme through the concept mapping, and 8 themes emerged. And I just want to draw your attention to a couple of them. So career and education were both very important when women thought about what goes into their intentions of becoming pregnant or not becoming pregnant. And you'll notice, although it was high for both, it was like #1 for the low income group. The higher income group, many of them, I would say almost the majority, had advanced degrees or working on advanced degrees, like your master level, and a couple of them were considering working on their doctorate or PhD. They were all, professionals working in their profession, whereas some folks in the lower income group, their goal was, I want to get my GED or I want to get an associate's degree. So it was very important to both of them, but in different ways. Jamie, could you make sure to let me know like 10 minutes beforehand, because I'll just talk all day. So give me a 10-minute alert. Self-reflection was very important to both groups. A lot of self-reflection, introspection, regardless of what the medical provider, their doctor, their partner said. It was really like, hey, this is my decision. And a lot of self-reflection went through that. The medical provider wasn't really a factor as much as we thought, even though some participants shared that they respected what their medical provider said, and that the medical provider had a lot to say about their birth control. Some, I would say coercive or borderline coercive, but they really didn't give the medical provider a lot of power in their decision making. And then my last point on this is when I saw this, I was like, wow. The other half, their partner was like, for both groups were like dead last in decision making. And I just thought that was extremely interesting. The higher income group talked more about men and about, my research happened in Milwaukee County. So they really talked about, hey, I have this education, I'm in my career. My next move, I really would like to be married and start a family, and my preference is to date and marry a Black man. And it's very hard to do in Milwaukee County. And then things came up about, incarceration rates for Black men, unemployment rates, discrimination rate, just the things that affect Black men. And of course, whatever is going to affect, a Black man or a Black woman, in fact, impacts the whole community. And so that really impacted them. They also talked about this strong Black women trope, that was sort of like thrust upon them, upon their family and their community, whereas the low income group never brought that up. They didn't talk about marriage or, having trouble dating Black men, and they didn't talk about the strong Black woman trope at all. So then now the UW-PRC research agenda. As I said before, each PRC has to have a core research agenda. The core research is really supposed to be the core of the center. Unfortunately, that didn't really happen last time. I think it was more like, here's the core research project and here's the center, and the two should not blend. And that I think was really unfortunate. What also was unfortunate is COVID happened. And, the core research project was addressing postpartum depression in Wisconsin home visiting programs. So COVID really impacted, and still is impacting the home visitation programs. They lost a lot of their staff. This is not like high paying, high reward, high prestige positions, and people found other employment. So a lot of home visiting have really been struggling. So our research struggled in this area as well. So I'm happy to say that our new core research project is Dr. Kier Hoppy's STACK program, and which I know you're all familiar with. So I'm super happy that I joke, but it's not really a joke, because I don't joke about trauma. It's really real, but I need to laugh about it, so I won't like cry about it. I think Dr. Hoppy and I like developed a trauma bond, because that was in working on that proposal, because it was a lot. It was a lot. It was a lot of pressure. But she is someone that I respect greatly, and she's become my mentor, my partner. And so the core research project really will be the core of the center. And Karen and I will make sure that it's integrated. We're both like really strong, sassy, tenacious women. And that's the way we'll be leading the core research project and the center. And so Dr. Happy's stack is going to go, she's taking it on the road. So out of Merida and into the community. So we'll for sure be in Milwaukee County, Dane County, hopefully, hopefully Racine Kenosha area, possibly Rock County. And we'll be utilizing doulas to help us. And of course, the in-home blood pressure monitoring. We'll be engaging family and community because our population is African-American women. And we had frank discussion about that. Kara's like, I'm not really sure if we limit it. And I'm like, Kara, I don't want to do that. What about isms? Because it's really number one. This is the number one reason that Black women are dying. Outside of homicide, that's a whole different story. And the number two is Native American women. And in some parts of the country, it's flipped. It's Native American women number one, and then African American women number two. But for Native American communities, you can't just knock on their door and say, hey, we have this research. We know it's going to be good for you. Let's have a relationship. That doesn't happen. And Dr. Dr. Happy has a relationship that a trusting relationship she's built within the African American community. That is what, I know if you say specialty is, that's what I spent the last, decade, my 2 or 3 decades, working within the Black community. So, I have already that established trust, not only because I'm a Black woman, that certainly helps, but because, I've been building these relationships in Milwaukee County and in Dane County. And so we realized that we need to be very intentional and very assertive about building relationships with Indigenous communities in Wisconsin. So I want to say we've already been doing that. We're not there yet, but we've been doing that. We've been very intentional. We have Indigenous folks on our community advisory board. We have been dabbling on how we can support them in different research efforts. And so that is our goal, is to move into Indigenous communities, either in this iteration of our grant, in finding other funding sources, or when we re-up in 2029, which we don't even want to talk about at this moment. But so really, really excited. I don't know if Dr. Happy is in the house, but shout out to her. She's a great person.
Dr. Denson, we have about 5 minutes left.
Okay, I'm going to go through this really fast. We also are doing research on where do infants go after when their mom is incarcerated and gives birth during incarceration. They have to go somewhere. The mom is usually back wherever she was, in Cheetah or some other institution after 2 days, and that baby has to go somewhere. And so we'll be doing that. We're also doing co-design for justice involved people, doulas, and peer support folks on what a doula project would look like for justice involved people. I'm doing formative evaluation for a Wisconsin doula project, which is in the CBPR model. These are just some of personal collaborations that I've had for years, or the last 2 I've had since I joined UW, which really informs my work and my leadership at the PRC. Opportunities for collaboration. There's a lot to do around maternal child health. We're always looking for collaborations on studies and projects. We have expertise in public health, community engaged research, Black racial health disparities, among many other things. If you're not signed up for our newsletter, that's a way to keep up with us. And we always have I'm always surprised, like every month, we always have lots of good information that I didn't know about. This is my crew, one of the best teams, I'm sure, on campus. really strong, skilled, supportive, collaborative team. These are them and their sorry, now I'm trying to rush, and what their positions are in their emails. So you can reach out to me or any one of them. And these other ways to stay connected with us. I really hope you do. Thank you for your time and attention. And I'll take any questions that you have in the time that I have allotted.
I have a comment, Luther Gaston. Yes. You ready?
I'm ready, Dr. Gasson.
Okay, so, I'm a numbers man. And so I was looking at the statistics in terms of numbers. You have white population, 2022 data, 219 million, 8.6% poverty rate, 18 million people. Black population, 41 million, 17% poverty rate, and 7.2 million people in poverty. So it's double the number of white people in America in poverty than Black people. When you look at government assistance welfare, white people are 43% of the people that are on government assistance and welfare. Latinos are next at 26%, Blacks at 23%, Asians at 8%. We were absolutely against public assistance when we grew up in my household in Chicago in 1970s. These are all stereotypes by the white population in the media that puts on us. But there's also an issue of we cannot solve this just through the healthcare system. This has to be solved through the social determinants of health. And there's something beyond poverty in Black and Native American patients that is driving this healthcare disparity. So I think it's beyond just the poverty issue. It's a really profound problem that has to do with the origins of this country that decimated Native Americans and Black people. And nobody wants to cry about it. I mean, I don't. But one of the things about it is that we have to realize that these are the two populations that are struggling the most, and there's a reason why that is. If we don't correct those social determinants of health, on our hospital stuff, I just had a great lecture at the University of Chicago. Our hospital care only will add about 15-20% to these outcomes. The vast majority of us changing healthcare outcomes is going to be in social determinants. That's at least my belief.
Yeah, I mean, I hope in my presentation I didn't give that interpretation. That's my whole point. And talking about historical trauma and talking about racism. When the first iteration of our current iteration really talked about for the health of women, infants, and children who are low income. And to me, low income was like a passive proxy for racism. And no, like you're not going to have a Serena Williams who is, I don't know whose body would be more in shape than hers, who is, very, very wealthy and, almost died because she wasn't listened to. I think healthcare has a part. A lot of these women are dying in healthcare situations, but by no means are healthcare or health providers they're a piece of the puzzle, but certainly not the whole puzzle. Not at all. Yes, social determinants, indigenous populations and Black populations have that historical trauma that permeates today. There's no way around that, and that is why they are all, those two groups are always going to have the worst social and medical outcomes.
Yep, I agree. When the health system was created, it was created on the basis this country had a choice to create universal health care, and it chose not to because after the slaves were freed, they were no longer of value. And so basically what they did was they wanted them to present later with disease and wanted them to have poor health. So that's why this is one of the only high-income countries that doesn't have universal health care. And so all of this is based on craziness, including the Social Security Act, which affected my grandparents, that really excluded domestic and housekeeping workers, who back then were the majority of Black people at gaining retirement and all that kind of stuff. So when people talk about, well, why do you always talk about race? Because the entire country was built on race.
Absolutely.
And the people that benefit from it, if they don't help solve this problem, we're going to be talking about this problem 100 years from now.
I agree.
Thank you so much.
Thank you, Dr. Gaston. Do you have time, Jamie, for one more question, or is there a question?
There's one more question in the crowd. Just 1 second.
Okay.
Thank you, Dr. Denson, for that presentation. My name is Ala. I'm one of the members of the graduating class in the residency program. The framework for community-based research is certainly different from how we're typically taught about research, kind of coming through medical school and even into residency. I'm wondering if you have recommendations for resources, conferences, CME opportunities for rising faculty and even established faculty who may be interested in dipping their toes into community-based research.
Well, congratulations, first of all, and thank you for listening. Well, I hope you stay connected with us because we, our newsletter, we always talk about, you know, if there is like a upcoming conference or talk, we do disseminate that through our newsletter. You know, the same for me. I got my PhD at UW Milwaukee, and the School of Public Health is like right in a distressed neighborhood, right adjacent to the infamous 53206 zip code. And I took a couple courses. I was able to take a couple courses, but it was really that traditional, what is best is, quantitative, get your big, data set. So a lot of what I know is really from me being a social worker, and then me intentionally joining groups like Black Mamas Matter Alliance, and other groups where they gave me, where I met people, learned about researchers who were doing this, published researchers, and really jumped onto their work. Looked for conferences where I could go to hear this kind of thing, because that's the way I was nurtured. That's the way that I'm learning. It wasn't from my institution. This is not valued. I think that we're starting to say that we're valuing community engaged research, but we're really not there yet. So you have to be intentional. You got to get on that Google. You have to get yourself involved in certain organizations, and then the more you get into it, the more you'll get information and learn.
Well, I can tell you from working in the Cabrini Green Housing Project when I was at Northwestern, I went back as an attending physician. And even though I was full-time, I got my master's in public health because that enabled me to see population health a little bit better. And it also, you have to have a dedication to the community. That's how you gain those ties. And that's why I stay in Milwaukee.
Awesome. I think that's time. Thank you so much, Dr. Denson, for your presentation.
Thank you all. I look forward to working with you guys. Bye.
Thank you. Great talk.
Thank you.
Thank you.